Bob Smith is the president and CEO of the Colorado Business Group on Health. And as I mentioned earlier, he has formed a purchasing group within Colorado Business Group on Health, and he's going to talk more about, he's going to talk to us about just his journey. You know, what has he done, what's he doing with all of the information, and some next steps he's considering. So Marilyn, we will bring you back during the panel discussion if you want to. There you go. And there's Bob hanging out in Colorado with that beautiful background. So thank you, Bob, for joining us. I'm glad you've recovered from COVID. That was really scary there. And thank you for being here today.
Well, thanks for the opportunity, Gloria. You can hear me okay, I take it?
Yes, we can hear you.
Great. Okay, excellent. Thanks. Well, no, it's such a pleasure to participate once again in the Employers Forum. For your members, I would just like to point out that both Gloria, your current leader, and Dave, your prior leader, they've really changed. If you can't tell, they've changed the discussion and really the direction of healthcare purchasing across the United States. So they're having an incredible impact. I also want to acknowledge both Chris Whaley's work, without which we would not know where we are in Colorado. And then, of course, Marilyn, you are a darn hard act to follow. We've been working incredibly closely with Marilyn. She's done an in-depth analysis of many of our front range hospitals here in Colorado, and her work is so essential for the employers to exercise their fiduciary responsibility. So my goal today would be to share with you how we've integrated Chris's work, what Gloria's instigated, what Marilyn has done, how we're using that work and building on that work here in Colorado, and particularly to focus less actually on the way providers provide care or even price their care, but particularly to focus on how purchasers purchase care. Because the question that we're obsessed with here is, can purchasers lead market-based health reform? So if you flip to the next slide, please. Gloria kind of highlighted some of this. I'll summarize it with three very brief statements that I think a body of literature going back to 1975 allows us to say. One, healthcare in the US is inconsistently effective. You can go to any one of those Medicare 5-star hospitals and you can find some of the worst outcomes in the United States. We see that kind of variability across hospitals, within service lines, across physicians, within physicians for individual procedures. Variation is ubiquitous. We know that healthcare is consistently inefficient by the lowest measures. We waste 25% on healthcare. That is more, by the way, than we spend on public education in the United States. And then the third thing I think you can say, and we've looked at this in great depth, is that it is increasingly and unjustifiably expensive. And I'll come back to that. And I make the unjustifiably both with regard to quality, because when we look at 58 non-critical access hospitals, we see that the lowest 9% or 9 hospitals have roughly the same outcomes across 36 service lines as the most expensive 9 hospitals. And then Marilyn's work helps us point out that or understand price is completely unrelated to cost, even within the same multi-hospital health system. But here's what we can't say about healthcare. We really can't say that it's broken. It works just as Dr. Berwick points out, it works just exactly the way you would predict it would work, given the way the dollars flow through the system. So the question is, can we purchase healthcare in a manner that doesn't cause this sort of market dysfunction? So if you flip to the next slide, Peter Drucker came out with just a marvelous HBR article almost 20 years ago or 30, whatever. And he says, when individual organizations or even industries like retail, mass transportation, other major industries, when they function with a high level of inefficiency and inconsistency, it's generally because the theory of the business model doesn't suit the current circumstances. And he points out, again, with railroads, think of Sears, every single theory of the business eventually becomes obsolete. So if you'd flip to the next slide, please, Sarah. So this is, I'll give you just 30 seconds to look at this, to read this quote. So we've operated, and I've been in the business nearly 50 years, not quite, but through that period of time, and actually going back to World War II, we've operated on the idea that only third parties, intermediaries, have the knowledge to control care, power to control or discipline the pricing, and a vested interest. So the question is, even if that theory was once right, has it become obsolescent? Okay, because in many ways, I think you could reasonably argue, it's the surrogates themselves who now cause many of the incentives for bad behavior in healthcare. For instance, one of the principal behaviors would be negotiating contracts as a percentage of discounts, because Maryland showed you the kind of cost to charge ratios that result directly from negotiating contracts based on a percent of Medicare. So it's the inevitable outcome of purchasing practices. Flip, if you would, to the next one. So the question is, can a free market, and this is what we're trying to do here in Colorado, can a free market make healthcare more efficient and effective? Can it create incentives to continuously improve value while getting providers to look at and re-engineer their costs? And what I would suggest is, we're not proposing to do away with health plans. We think that health plans and health insurers, administrators play an important role. But here's what we would propose: two major changes if the marketplace is to work. And without these two, I don't see how it can be made to work. One, employers have to quit purchasing healthcare individually. They must purchase healthcare collectively as a collaborative. And we were formed as a co-op under a Colorado revised statute that I'll talk more about. The second thing they need to do is then directly engage with the providers in a dialogue or a discussion. How do we improve performance? Because we know, particularly with complex care, and the more complex the care, the more the employers have a responsibility to get employees engaged in the care process. And so the employers and the providers really need to work together. And instead of the health plan being a wall between the buyers and the sellers, that's absolutely impenetrable, we really need them to be a floor for the traditional dance that a buyer and a seller should do in a marketplace. So Sarah, if you'd flip to the next slide. I've now completely abandoned my notes. Very briefly, what this shows is that we are a brand new, the Colorado Business Group on Health did form a separate organization. We are a purchasing co-op. We're not offering insurance. We're not offering third-party administrative services. We're not offering consulting, but we are looking to do group purchasing and group contracting. As part of this plan, which has been adopted by the state of Colorado and Governor Polis directly, the governor committed to me personally that if we would create this kind of a structure, the state of Colorado would be the first purchaser in, which they were. We have other purchasers, include the city and county of Denver, the statewide Public Employee Retirement Association. We have a number of mid-size school districts. We're hoping to get one or two of our largest, and a couple of Taft-Hartley plans to whom I don't have to explain collective bargaining. We also have some non-voting seats. The Colorado Consumer Health Initiative regularly participates. We work very closely with RAND. We work with the Center for Improving Healthcare Value. They manage our all payer claims database. The CMS is the small CMS, as we refer to it, Colorado Medical Society, because we're looking to work with the physicians in a more physician-directed model to say what should the standards be. And then we've been very marvelously supported by Marilyn Bartlett and the National Academy. So if you flip to the next slide, that represents probably 85,000 employees or enrollees, and roughly twice that. And we think that we'll probably need again to double the number of participants if we're to pull off this particular vision. So if the theory of the business has been wrong, how do we propose to change it? And here's how, and I'll keep an eye on the clock. Here's how. Rather than third parties negotiate contracts in a manner that benefits them, and by the way, if they're publicly traded, then they have a responsibility to purchase healthcare in a way that best improves their bottom line. And that's worth keeping in mind. So they typically then negotiate discounts as a percent of facility charges. Well, Maryland has shown you, and I'll show you for Colorado, what those cost to charge ratios look like. And then the employers in turn, typically without any sort of due diligence, just contract with the network. We really need to change that to where we use the employers themselves do direct purchasing. The employers then negotiate contracts. If you don't know what you're paying as a percent of Medicare, you really don't know what you're paying. And so we want to use the same due diligence, both with regard to hospital costs and with regard to hospital quality at the service line level. The second thing then, just putting that structure in place is a prerequisite, but a real success factor then becomes we need for the first time ever to create meaningful incentives to get employees to use advanced primary care, to use the higher quality specialists, okay, and to use lower cost sites of care. And the difference between freestanding and hospital-based has already been discussed. And then the third thing is this: the long-term, the eye on the prize, if you will. What we're trying to do is to recognize that we need to return control of the marketplace to physicians. We need to use alternative payment models like episodes that put physicians in charge of how resources get spent and work with those physicians, because we cannot afford the corporate practice of medicine. And you see that in Indiana pretty much in spades. Flip to the next slide, if you would. So those are the three disruptors, and it's something of a hierarchy. This I'll just touch on. If a marketplace is to work, and this was in, and I think I don't know, Gloria's or Marilyn's slide. We emphasize value-based plan designs, and that's because the employer must act. Every organization is individually different and unique. So every employer has to think through over a multi-year period, what would be the plan design that best moves people to primary care, toward high-performing specialists, and to cost-effective sites of care, as I mentioned a moment ago. So we have to affect the demand side, and the employer has to do that individually. But then the employer must, on our model, collectively, impact the supply side. And what we've proposed there, and I'll tell you the results of this. We had first approached the less expensive of the 7 health systems across the state. We approached the less expensive. Well, we spoke with all of the health systems. I'll give you a summary update in a minute of what the responses have been. But we tried to work with the less expensive. Negotiating a fair reference-based price. We used Gloria's work, and we said, look, we will calculate what your break even is. And even, for instance, in the health system, one of the systems we worked with had 6 different hospitals. The most expensive on a risk-adjusted basis had twice the costs of medical care using Maryland's cost of care model as its least expensive. And what we suggested is we'll meet you in the middle. We'll meet each hospital where it's at, and then we'll build on top of that a margin that we'd like them to work on over a period of time. So that's how we used Maryland's work, and I'll tell you how that went in a minute. So flip to the next, and we said we would work on this over a multi-year period. So Maryland's work, we applied to roughly 35 hospitals on the Front Range. And surprisingly enough, or unsurprisingly, Maryland showed you for Indiana, the cost to charge ratio was 20%. We've seen for those 35 hospitals, it's on average 20 to 25%, but we've seen, hospitals where it's 5, 6, 700, or even 10 times greater than the cost of care. One of the biggest points of argument we've had, by the way, as we went through these data, was exactly what Marilyn talked about, and that was the Medicare exclusions. So at any rate, what we see in Colorado is Medicare represents about 26% of the patient mix. Hospitals do lose, those 35 hospitals lose about 11% on Medicare. The question I have is why? When the MedPAC, Medicare Payment Advisory Committee, reports to Congress that relatively efficient hospitals lost 2% this past report and 0%, then why are we losing 11 on Medicare? And why do we lose 32% on Medicaid in view of the fact that we have a supplemental fee? Profit margins can run 46% across these, and here's the kicker on the bottom. When we look at the break even, what we calculated was that Colorado hospitals needed 153% to break even. Again, I might expect a more reasonable number to be 110 to 120, but let's say it's 153%. The surrogate purchasers today are paying 312%, which strikes me as pretty high. So if you go to the next slide, Sarah, and I think I'm doing okay on time. So what was the response? Well, first of all, the response, by the way, from community-based, from independent hospitals has been really exceptional. They welcomed Gloria's work. We dug into it. It was very, very well accepted. And we're in the process of negotiating a number of contracts based on Gloria's work. The health systems, not so much.
I'm just going to clarify, Bob. I wish I could take credit for it.
I'm sorry, Marilyn's work.
Marilyn's
work. Damn. Yep. And I keep doing that. I don't know why. I'm sorry.
That's okay. I want to give Marilyn credit because
No, thank you very much. And so we've had by the way, we've shared it. I mean, we completely opened the kimono. We showed them the evaluations. We showed them spreadsheet after spreadsheet. And by the way, all the health systems originally agreed. Oh yeah, this is great stuff. We'll sit down and we'll do this. And then in the end, it came down to, well, yeah, we may be priced at 320% of Medicare, but if we work with you to reduce our prices, aren't we just discounting our existing books of business? And what are we going to get out of this? And you can see some of the quotes, and these are literally verbatim quotes from some of the different health systems. And I won't read them to you except for this first one, because the first one is the one that's really the most informative. This was in an article in the Colorado Times Recorder back in March. And this is the CEO of one of our two largest systems. And he said, look, and I just appreciate this man's honesty. He said, look, that by everybody, by the way, he was not referring to school systems, because half of our schools operate on a 4-day week due to lack of funds. So he was talking, when he says everybody, by health plans and health systems. And he says, no, everybody's fat and happy. The payers and the providers don't want to change. And basically no one wants to disrupt the marketplace. And that pretty much describes all of the quotes below. In fact, the fourth bullet there, or whatever it is, it says, don't bother recalculating our cost of care. That was when we got into a discussion about, well, if your physicians are generating as much or more revenue as their expenses, why do we want to cover those expenses? And she said that the representative said, well, listen, don't bother recalculating all this. That's a lot of work. We'll just tell you what the prices are that we'll accept. Okay. So if you go to the next slide, Sarah. And I think I'm just about going to wrap it up here. If you Google oligopoly or oligopolistic behaviors, basically what you will see is the kind of responses we've had from many of these health systems. Mr. Benko's quote is that really, I mean, the systems just don't see a lot of advantage to competing on these questions. And I'm just telling you what the experience has been over the last 9 months. Even those health systems, this was really interesting because it's not just individual systems, it's the marketplace itself that is self-perpetuating. Because even those systems that would or could have significantly gained in terms of either changing their market payer mix or even payments, they were afraid of the business risk of the health plans going back to them and demanding further cuts. And so the systems which complain about the way the marketplace works are afraid of changing the way the marketplace works. The third bullet, this is just a problem, and I've observed this in the market for 25 years. National health plans not only have national strategies for realizing historic profits, but they have national infrastructure. They have no interest in being marginalized, and have something of a fear of being marginalized, which they largely see us as doing. Now, the third-party administrators we've had no issues with. Third-party administrators more than happy to work with us. But the health plans have these infrastructures. They were built around their actuarial models. They're built around the way they punch and pay claims. And frankly, for the most part, they don't even have the flexibility to work with us. And then here's maybe, in a sense, I've flipped when I put this slide deck together to put this maybe at the top. When we originally started out, we had very good discussions with the CFOs or CEOs of these systems about defining a strategic approach that would work to the mutual advantage, and particularly to that of the community. And then with COVID, the CEOs, of course, were understandably distracted and trying to take care of this national epidemic. And so now the folks that we've dealt with have just really strictly been very transactional, and it's very difficult to restructure a market to make meaningful headway with folks that are simply transactional. So what are the opportunities? Well, thankfully, as I mentioned, we do have a number of independent and community hospitals, and these folks understand that they're there to serve their community. They don't have to pass their revenues on to some larger system. And we have very collaborative, very positive relationships that we're developing with these folks. We have a number of advanced primary care practices. We don't have and at least one in each of the major MSAs in Denver, a couple of advanced primary care practices. And what we're looking to do is work with these folks in a manner that rewards advanced practice primary care. And then happily, in some of the MSAs, we do have quite a few freestanding centers. And again, long-term, we can't afford the corporate practice of medicine. So we are looking I mean, these, and we're doing an analysis, and Chris Whaley, I may look for you for some input, running an analysis of our all payer claims database that for our 14 purchasers, if we moved the 10 most frequent outpatient services from a hospital basis to a freestanding center, what would the savings be? We've seen other purchasers do that. So that's one of the things that we're looking at. So here's the closing note. And I think, Gloria, you gave me 25 minutes and I'm at 23:30. The success factor, I mean, we can put the infrastructure in place and all that sort of thing, but the real success factor is the will, the resolve, the courage of the purchasers, employers, Taft-Hartley plans, employers trust, to recreate a marketplace that rewards value. Not just being big, but being good. That's what we want to reward. So that's what we're working on. Gloria, I'll turn it back to you.